Hello doctors, today we are here with another very important topic of general surgery, that is varicose vein. First, we will start with the anatomy of the varicose vein. You have to know that there are two type of venous system in our body. One is the superficial, another one is deep. And varicose vein is common in the legs. Therefore, we will see the anatomy of veins in the leg. So 20% of blood is flowing through the superficial venous system and 80% through the deep venous system. Now, the deep venous system in leg, there are three main deep veins in the leg, that is anterior tibial vein, usually paired, then posterior tibial vein, which is also paired, and peroneal veins. These are the three deep veins that is present in our leg, and around the knee joint we have the popliteal vein, that is a deep vein. Now, great saphenous vein, GSV means great saphenous vein. Great saphenous vein is present anterior to the medial malleolus, medial end of the dorsal venous arch. In the anatomy, you have read about the dorsal venous arch in the foot. So, the medial end of the dorsal venous arch in the medial malleolus, anterior to it. Remember, anterior to medial malleolus, not posterior to medial malleolus. Then it goes to the medial aspect of the knee, then it goes to the saphenofemoral junction and it drains into the femoral vein. And saphenofemoral junction have a constant location. Remember, saphenofemoral junction have a constant location, which is 4 centimeter below and lateral to the pubic tubercle, is the constant location of the saphenofemoral junction. And great saphenous vein just below the knee is associated with the saphenous nerve. Great saphenous vein below the knee is associated with the saphenous nerve. Now we have another vein, that is accessory saphenous vein. Accessory saphenous vein, here in the picture you can see, accessory saphenous vein is present over the lateral aspect of the knee. It is present over the lateral aspect of the knee, is the accessory saphenous vein. Then we have the short saphenous vein. Short saphenous vein is present over the lateral end of the dorsal venous arch. Great saphenous vein is present over the medial end of the dorsal venous arch, and short saphenous vein is present over the lateral end of the dorsal venous arch, which travels posteriorly and it drains into the saphenopopliteal junction. I have already told you saphenofemoral junction have a constant location, but saphenopopliteal junction have the variable location, and there is higher chance of recurrence even after operation in saphenopopliteal junction. And short saphenous vein is closely associated with sural nerve along its course. We do not strip the short saphenous vein. So remember, great saphenous vein is associated with saphenous nerve. Saphenous nerve, which is present below the knee. Above the knee, the saphenous nerve is not closely associated with the great saphenous vein. But in cases of short saphenous vein, throughout the course of the short saphenous vein, sural nerve is closely associated with it. Therefore, we never do stripping in short saphenous vein. So this is all about the great saphenous vein, short saphenous vein, and the accessory saphenous vein. We have another vein, that is vein of Giacomin. Remember this, vein of Giacomin is cranial extension of small saphenous vein. When the short saphenous vein is extended cranially, generally short saphenous vein goes and it drains into the saphenopopliteal junction. But sometimes it extends cranially, then it is known as vein of Giacomin. So vein of Giacomin is cranial extension of short saphenous vein, is known as vein of Giacomin. Now we will see about the perforators. There are 100 to 150 perforators in a leg, but we will read some of the named perforators. Some of the named perforator are the perforator which is present in the thigh is known as Hunterian perforator. Above the knee it is known as Dodd, and below the knee it is known as Boyd. I remember this like B for below and B for Boyd. So below the knee is the boyd and above the knee is dod. Just remember, people get confused in these two. Then we have the cocket perforator. Cocket perforator, there are three, that is 5 centimeter, 10 centimeter and 15 centimeter above the medial malleolus. This is the cocket perforator. Then we have May Kushner perforator around the heel. Another perforator, that is Basie's perforator, that is present in the para Achilles region. This is known as Basie's perforator. So we have the Hunterian perforator, Dodd, Boyd, Cocket, May Kushner and Basie's. And largest perforator, if it is asked in question, the largest perforator, then the largest perforator is the saphenofemoral junction, where the great saphenous vein drains into the femoral vein. Now, what is the normal pathophysiology? Generally, blood is returned against the gravity in cases of leg. During inspiration, there is reduction in the intrathoracic pressure and compression of the surrounding muscle increases the flow. On exercise, reduction in pressure in the superficial vein. If the pressure increases, the ambulatory venous hypertension we call it. So what is varicose vein? The definition of varicose vein is dilated tortuous vein with defective valves. Dilated tortuous vein with defective valve. Now, the varicose vein can be primary or secondary. Primary means there is problem in valve. Either it is a defective valve present or absent valve, congenitally there is absent valve. Then it is known as primary cause of varicose vein. In secondary cause of varicose vein means it is not due to valve, it is due to some other causes like secondary to DVT, that is post thrombotic limb, secondary to abdominal or pelvic tumor. Varicosity will extend above the inguinal region. If varicose vein is present because of abdominal or pelvic tumor, then we can see the varicosity above the inguinal ligament. And if the patient have a history, family history or occupational risk, females have more chances of varicose vein than males. Obese patient, in pregnant patient, these are the secondary causes of the varicose vein, and primary cause is the defective and the absent valve. So these are the causes of varicose vein. Now, in dilated vein, if the vein is dilated for less than 1 mm, then it is known as dermal flare or thread vein. These are known as dermal flare or thread veins. If it is 1 to 3 mm in size, it is known as reticular vein. And if it is more than 3 mm in size, then it is known as varicose vein. So varicose vein is when the vein is dilated more than 3 mm. Then it is a varicose vein. If it is 1 to 3 mm, then it is a reticular vein. If it is less than 1 mm, then it is a dermal flare or thread vein. Patient will present with to you clinical features in varicose vein. Patient will present to you with dilated veins, with dull aching pain in the leg, and there will be pigmentation due to hemosiderin deposition. So why there is pigmentation in varicose vein? Due to hemosiderin deposition. Now, if there is varicose vein plus reticular vein, means 1 to 3 mm size is the reticular vein, then there will be functional plus cosmetic problems will be there. And if the venous size is less than 1 mm, then it is known as dermal flare. And if there is only dermal flare present, then it is a cosmetic problem. Patient doesn't have any kind of functional problem. Here you can see a picture. This is a picture of varicose vein and we can see pigmentation here. The pigmentation is because of hemosiderin deposition. And this is the thread veins. You can see mild dilated veins are present here. These are the thread veins. Thread veins have the cosmetic problems, no functional problem. Now we will see corona phlebitictia. Corona phlebitictia is known as malleolar flare. It is a fan-shaped pattern of telangiectasia, intradermal venules less than 1 mm in diameter on the ankle or foot region. It is thought to be an early sign of advanced venous disease. So this is around the ankle. If there is a malleolar flare present, it is known as corona phlebitictia. Remember. Now what is atropia blancae? Atropia blancae is pale white area surrounded by dermal flare or thread vein. When there are dermal flare, thread veins are present like less than 1 mm, but there is a whitish patch. Here you can see there is a whitish patch present here. This is known as atropia blancae. Now we have to know another important term very commonly asked in NEET PG exam, that is lipodermatosclerosis. Lipodermatosclerosis is, here you can see this is a woody feel will be present and contracture of tendo-achilles will be there in lipodermatosclerosis, and this is known as inverted champagne bottle appearance. The inverted champagne bottle appearance is seen in lipodermatosclerosis. This is an important point to remember. Now we will see ulcerations. Here you can see this is a picture of venous ulceration. Now we will have a very important classification important for your exam, that is CEAP classification. C is for clinical, E for etiological, A for anatomical, and P for pathophysiological. So C for clinical, we will start with the clinical. C0 means there is no visible or palpable signs of venous disease, means there is no sign of venous disease present is C0. Then we have the C1. C1 means there is telangiectasia or reticular vein. Reticular vein is 1 to 3 mm in size. Remember, very important, C2 is the varicose vein, very important. And if C2R is written, R means recurrent varicose vein. C3 is edema. C4 is changes in skin and subcutaneous tissue secondary to chronic venous disease. So C2, remember, it is varicose vein. C3 is edema. C4A is pigmentation. C4B is lipodermatosclerosis. I have already told you lipodermatosclerosis is contracture of the tendo-achilles and it has an inverted champagne bottle appearance. And atropia blancae means atropia blancae will have a whitish patch around the dermal flare. And C4C is the corona flavectasia. Corona flavectasia is flare around the malleolar. C5 is the healed ulcer. C6 is active venous ulcer. And R means recurrent active venous ulcer. So this is the C, that is clinical classification of the varicose vein. I will tell again, this is very important for your MCQ exam. That is C0 is no visible vein, C1 is telangiectasia or reticular vein, C2 is varicose vein, C3 is edema, C4A is pigmentation or eczema, C4B is lipodermatosclerosis or atropia blancae, C4C is corona flavectasia, C5 is healed venous ulcer, and C6 is active venous ulcer, out of which remember C2 and all the C4, specifically C4B. These two are very important, you have to remember. Now E for is etiological. Etiological means if it is written EC, then C stands for congenital. Like patient have congenital absent valve, then patient will have varicose vein. So it is known as C for congenital, P for primary, either defective valve or absent valve is a primary cause. CES means secondary. Secondary means secondary to DVT or secondary to abdominal or pelvic tumor or having a family history is the secondary cause. And N means no venous etiology is identified yet. So this is the etiological classification. Now A for anatomical classification. Anatomy means which vein is involved. If S means superficial veins are involved. P means perforators are involved. D means deep veins are involved. N means no venous location is identified. So this is the anatomical classification. Now pathophysiological classification. Pathophysiological classification is R for recurrent, O for obstruction. R and O both means reflux and obstruction. N for no venous pathophysiology identifiable. So this is the CEAP classification, very important for your exam. Now we will have some of the tests to varicose vein to know whether the saphenofemoral junction is incompetent or whether the perforators are incompetent or there is defect in the valves. So first test, which is you have already done in your clinical posting in 4th year of MBBS. First is the Trenaury test. Trenaury test, first you have to empty the veins. While lifting up the leg, you will empty the vein. After emptying the vein, you will tie the tourniquet just below the saphenofemoral junction. Then you will ask the patient to stand up. When the patient stands up, immediately open the tourniquet. If there is a rapid filling present, then means there is incompetent in saphenofemoral junction. Like after opening the tourniquet, if there is rapid filling, means saphenofemoral junction was the problem, and when you open it, the blood comes back into the superficial veins. So there is defective saphenofemoral junction. Now we will again milk the veins, then we will tie a tourniquet, then we will ask the patient to stand up, but this time we will not open the tourniquet and we will wait. If there is feeling of veins from below, even if the saphenofemoral junction is tied, still there is feeling of veins from below, means there is incompetence in perforators present. So this is how you will identify whether the saphenofemoral junction is incompetent or perforator is incompetent. Now there are some other clinical signs like Morse's cuff impulse, that is asks the patient to cuff. If the cuff impulse at saphenofemoral junction, you can feel the cuff impulse, then there is incompetent saphenofemoral junction. Then we have the Swartz test, that is tap over the vein. If the thrill is present at the saphenofemoral junction, then the saphenofemoral junction is incompetent. Then we have the Figan's test. Figan's method and multiple tourniquet test, that is identify the location of incompetent perforator. You do the Figan's test to know the incompetent perforator. Then we have the modified Perthes test. Modified Perthes test is done to rule out the DVT, that is to tie a tourniquet without emptying the vein. In Trenaury's test, first we empty the vein, then we tie the tourniquet. But in modified Perthes test, we will tie the tourniquet without emptying the vein below the saphenofemoral junction. Then we will ask the patient to stand up and we will tell the patient to walk. If the vein will collapse and the pain decreases, then it is normal, which happens in a normal individual. But if the pain increases on walking, then we have the chances of, we will suspect that patient will have DVT. So this is a test for DVT, that is modified Perthes test. Then so we have read about the Trenaury test, Morris's cuff reflex, Swartz test, Figan's test, and modified Perthes test. And all these clinical tests are generally not done because they have very low sensitivity. We generally directly advise the patient to have a USG Doppler study or duplex study, that is Doppler study with B mode of USG is known as duplex study. Now duplex study tells us about the flow, direction of flow, whether it is away from heart, then it shows the red color. If it is towards the heart, then it shows the blue color. And duplex can also shows reflux of the vein is present or not. Superficial vein reflux is identified as retrograde flow lasting 0.5 seconds or more. In duplex scan, we will see the Mickey Mouse sign. So this is the Mickey Mouse sign. Two ears are formed by the CFA, means common femoral artery, GSV means great saphenous vein, and the mouth of the face of the Mickey Mouse is formed by the femoral vein. So this forms the Mickey Mouse sign. Femoral artery, femoral vein, and great saphenous vein forms the Mickey Mouse sign. Now, what is the management of varicose vein? We have seen the clinical feature. Now we will see the management of varicose vein. So management can be conservative or definitive management. Adjunct management means when there is just starting of varicose vein, grade 1, only varicose vein is present. Then either we can give compression stockings to this patient or we can give dressing garments. The compression stocking have 4 classes: class 1, class 2, class 3 and class 4. Class 1 means the pressure is 14 to 17 mm of Hg. In class 2, the pressure is 18 to 24 mm of Hg. In class 3, the pressure is 25 to 35 mm of Hg. And in class 4, the pressure is more than 35 mm of Hg. So these are the compression stockings class. Generally in varicose vein, we give the class 3 compression stocking, but the patient generally have the low compliance. Patient doesn't wear the compression stocking always because it is very uncomfortable for the patient. So this is the adjunct treatment. Then we have the definitive treatment. Definitive treatment is the surgery. We have to do surgery in these cases. Now first we will have to see whether there is a problem in great saphenous vein or short saphenous vein, or there is problem in the perforator. So we will start with the great saphenous vein. In great saphenous vein, and if the saphenofemoral junction is incompetent, traditionally, like from the beginning, we do the Trendelenburg procedure. That is the previously I have told you about the Trendelenburg test, and this is the Trendelenburg procedure. What is Trendelenburg procedure? It is flush ligation of the saphenofemoral junction. Means flush means as close to the junction as possible, because if we do not do the flush ligation, then we will leave a stump behind, and if we leave a stump behind, there will be a high chances of the saphenavarics formation. Therefore, always do the flush ligation of the saphenofemoral junction. After ligating the saphenofemoral junction, this is the saphenofemoral junction where the great saphenous vein drains into the femoral vein. In the saphenofemoral junction, we have 6 tributaries, which is very important and asked in Viva question in MBBS. 6 tributaries are: number 1, medial. Medially, we have the superficial external pudendal and deep external pudendal. Distally, we have the accessory anterior saphenous vein and the posterior medial thigh vein. And laterally, we have the superficial epigastric vein and the superficial circumflex iliac vein. So these are the tributaries that present over the saphenofemoral junction. If we do not ligate these tributaries, then there will be a high recurrence of the varicose vein. So remember these tributaries, and you have to ligate them during the surgery. Now, we also do stripping of veins in cases of great saphenous vein till up to the knee, because I have told you earlier in the anatomy that saphenous nerve is very closely related to the great saphenous vein. Therefore, we can do the stripping till the knee. Below that, saphenous nerve is very closely associated with the great saphenous vein. Therefore, stripping should be done till the knee, not below the knee, as saphenous nerve injury chances are very high. So this is all about the great saphenous vein. Now we will see the second, that is the short saphenous vein and the saphenopopliteal junction incompetence. In this case also, we will do the flush ligation of the saphenopopliteal junction in the saphenopopliteal junction. And in short saphenous vein, I have already told you, we do not do stripping, because if we do stripping, there will be high chances of sural nerve injury, and throughout the course of the short saphenous vein, sural nerve is very closely associated with it. Therefore, no stripping in short saphenous vein. In the latest, we have the EVLT and RFA. Now we have the perforator incompetent. Perforator, we have already told you about the named perforator, Dodd and Cockett, multiple subfacial ligation of the perforators and cosmetically inferior. Therefore, in perforator surgery, when there is a perforator incompetence, we do CEAPS. Very important. CEAPS is subfacial endoscopic perforator surgery. Because if there are multiple perforator present, and if we cut the perforator one by one and we ligate them, there it is very cosmetically inferior. Therefore, we do the CEAPS, that is subfacial endoscopic perforator surgery, and latest we do the EVLT and RFA. Now, we have some of the newer modalities of treatment in varicose vein. Number 1 is the endovenous glue therapy, like a gum, Febicol. It is a glue therapy, and the glue that we use to close the varicose vein is the cyanoacrylate glue. Then we have the Trivex procedure, that is trans-illuminated powered phlebectomy. Then we have the foam therapy. In foam therapy, we've used the sclerosing agent. Most commonly, it is sodium tetradecyl sulfate. But foam therapy have a very high recurrence rate, and foam is created in either in ratio of 1:3 or 1:4, and it is given in veins which are less than 3 mm in diameter. So, and this foam sclerotherapy mixing technique is known as Tessari technique. Either one sclerosant is taken and 3 ratio of air, or 1:4 ratio is used. And by this way, as you can see in this picture, we can we create the sclerotherapy agent and we inject them into the veins. So this is the foam therapy, sclerotherapy, which is the latest technique. Now we have already told you about the EVLT or RFA technique. EVLT is known as endovenous laser therapy. Laser means, as you can tell that in the name, laser means we use the laser in the patient. 1470 nm laser, 60 joule per centimeter heat is produced. Forward firing or lateral firing is done. Better is the lateral firing than forward firing, It is more uniform distribution and less risk of perforation is present. So latest is the EVLT, preferred because it has a less recurrence and faster recovery. Then we have the RFA. RFA is the radio frequency ablation. Radio frequency ablation, temperature is 120 degree. 20 cycles are given. Shorter learning curve and continuous pullback is not required in this case, in this type. How we do the endovenous laser therapy? We have the leg of the patient. Suppose this is the vein that we have. In EVLT, we put the laser probe here and we go up to the great saphenous vein or saphanopopliteal junction. Then we fire the laser. We fire the laser here endovenously. Then we pull back. Then we again fire here. Then we pull back. Then we again fire. Now, like that, we pull back and fire up to the required vein that we want to obliterate. This is how we do the EVLT, and RFA is done via the temperature technique, that is 120 degrees used via the radio frequency. So this is about EVLT and RFA. Now what are the complications of varicose vein surgery? One is the wound infection. It is common in every type of surgery and this is the most common complication in varicose vein surgery. Then the patient might have bruising, recurrence, short saphenous vein and great saphenous vein. Short saphenous vein have higher chances of recurrence than great saphenous vein. Then patient might have bleeding, injury to the nerves like saphenous nerve or sural nerve, and injury to the vessels around it. So these are the complications of the varicose vein. Now we will know about the venous ulcers. Venous ulcer means ambulatory venous hypertension. Most common site for venous ulcer is the Guyat's area. Remember this, most common site of venous ulcer, that is around the medial malleolus. Then second most common is the lateral malleolus around the short saphenous vein. What are the features of venous ulcer? Venous ulcer will have the shallow edge, sloping edges, shallow, pale granulation tissues are present and pigmented margins. Always examine for the pulsation of the artery because most of the time venous ulcer is associated with the arterial diseases also. Therefore, always examine for the pulsation. What is the management of the venous ulcer? Venous ulcer, we have the Bisgard regimen. Bisgard regimen is education, elevation of limb, elastic compression stocking should be given, dressing of the venous ulcer and surgery. Level 1 evidence and reduces the recurrence. Pentoxifylline is the only drug approved because it increases the microvascular perfusion. Therefore, we can give pentoxifylline in cases of venous ulcer. And compression stocking can be made up of wool, cotton crepe, elastic bandage or cohesive bandage. And we give the pressure of 30 to 40 mm of Hg. In venous ulcer, we give class 3 or class 4 compression stocking in these patients, and pentoxifylline is an approved drug. If arterial disease are also present, then if the ABPI is 0.5 to in between 0.5 to 0.8, then 30 mm of Hg pressure can be given, not more than that. Now we have another very important topic, that is Marjolin ulcer. This picture you have to remember. Marjolin ulcer looks like a cauliflower. This looks like a cauliflower. These have a everted edges. In the venous ulcer, we have the sloping edges, but in cases of Marjolin ulcer, we have the everted edges. Why this occurs? Either it occurs due to long-standing venous ulcer or due to a burn scar. Due to a burn scar, there will be a Marjolin ulcer, and later on, it will convert into a squamous cell carcinoma, and it will have an everted edges, and squamous cell carcinoma have a cauliflower like appearance. In these cases, we have to do the surgical excision, and radiotherapy is generally avoided in cases of marginal ulcer. You have to know two main terms. One is the KLIPPEL-TRENAURY syndrome. What is KLIPPEL-TRENAURY syndrome? Remember, KLIPPEL-TRENAURY syndrome is absent deep veins. Very important. Just remember this point. KLIPPEL-TRENAURY syndrome will have the varicose vein plus there will be absent deep veins congenitally, and it is managed conservatively. As the deep veins are absent, we cannot remove the varicose vein. If there is superficial vein and deep vein, both are present, then only we can strip off the superficial vein. But congenitally, if the deep veins are absent, we cannot strip off the superficial vein. Therefore, in KLIPPEL TRENAURY syndrome, it is managed conservatively. Another very important is the Parkes-Weber syndrome. In Parkes-Weber syndrome, there will be multiple AV fistulas, and these fistula will cause high output failure. So this is all about the varicose vein. Thank you for watching, guys. If you want videos on some specific topics, please mention them in the comment section below. Thank you.